another edition of Health Options. Globally and in Nigeria, there are several millions of people who are HIV positive and do not know their status. HIV prevalence is relatively low in Nigeria, but its large population means that over 3 million people are living with HIV, making it the country with the second largest number of people living with the virus in the world. Current statistics indicate that up to 62% are not aware of their HIV status. The global community observed the 2018 World AIDS Day with the theme, Know Your Status, which aims at getting more people to get tested and know their status. It is on that premise that Health Options will evaluate the country's efforts at dealing with the HIV and AIDS pandemic and progress at meeting the global target of ending the scourge by the year 2030. Thanks for joining us on the program. I am Rabi Abdallah. Before we get down to our topic, let's take this report by Chindema in the BC.
According to available records, only 38% of people living with HIV in Nigeria know their status. This, experts say, is not looking good for a country of about 200 million people that is working to achieve an AIDS-free nation with zero new infection and AIDS-related discrimination. To bridge this gap, Nigeria, through the National Agency for the Control of AIDS, NACA, is aligning with this year's World AIDS Day theme, Know Your Status, to provide more free HIV testing centers across the country. Individuals can now also use self-testing kits. To gain more grounds on the elimination of mother-to-child transmission of HIV and AIDS, which is currently at 50%, all pregnant women are encouraged to access antenatal care where free HIV testing is provided.
We have now restored our relationship with the international community and in particular our major funders.
Walk to any ART centers or in fact any HIV units or any hospital and request for HIV tests. And if you are HIV positive, the treatment is available free.
We shouldn't forget to have intervention specifically looking at tackling stigma.
NACA has also secured state government's commitment to put in 0.5 to 1% of their monthly allocations towards HIV and AIDS intervention programs.
Many thanks, Chidema. With me in the studio to evaluate Nigeria's fight against the HIV and AIDS pandemic is the Director General of the National Agency for the Control of HIV and AIDS, Dr. Sani Aliyu. Welcome to Health Options, Dr. Aliyu.
Thank you for having me, Rabi.
All right. Talking about HIV and AIDS, we're drawing attention on the need for us to step up our acts and curb stigma and other issues we need to address. And we're looking at the need for people to get tested and know their HIV status this time around. Let us into the Nigerian situation before we really get down to the topic.
Thank you, Rabi. So, as you said earlier on, we have, as a country, we have a prevalence of about 3%, which translates to about 3 million Nigerians living with the virus. Of the 3 million living with the virus, only 1.1 million are currently on treatment, close to 1.1 million, which means that we have about 1.9 million that either do not know that they have HIV or, for a very small proportion of them, know that they have HIV but are not on treatment. The theme for this year's World AIDS Day is all about knowing your status, because what we are hoping to do is to try and bridge that gap in the number of people currently diagnosed with HIV. We're currently in the midst of doing a major national survey which will give us even more accurate figures in terms of the estimates of people living with HIV, but we're very confident that we still have a gap because there are still people out there that are undiagnosed. The problem with HIV is, even though it's no longer a death sentence, but if you're diagnosed late, you may have run out of time. For you to be able to benefit from the drugs that we have, you need to have the diagnosis made early before you get very sick. The drugs work very well. They're taking only 1 tablet once a day. They are very tolerable, and we give them out for free. So you don't even need to pay anything in order to access the drugs.
Okay, the renewed impetus on getting people to get tested and know their status means that there's going to be an upsurge, in the number of people who will eventually get to know their status. And I'm looking at the deficit in terms of the treatment gaps now. We know over 3 million people are infected. Just slightly, more than half of that, number are on treatment. How do you intend to address that?
So it's interesting you mentioned the gap,
yes.
But what we do know from our program with partners is the difficulty sometimes in terms of getting new positives. There are parts of the country, if you go and test, it's very difficult to get one case. You have to test thousands. In fact, if you look at our programs, both the US government program and the Global Fund program, based on the targets they've had, they will be given a target of, let's say, to put 80,000 people on treatment. They'll go and test, and they can't find 80,000 within a year. Based on the targets, ideally we should have 1.5 million Nigerians, about 1.5 million Nigerians now on treatment, which means that the money was actually provided for us to put 1.5 million. But we currently have 1.1 because people are just not coming out to get tested. There's also the need to change the way we are testing, because there are certain groups that have a higher risk of getting HIV. So what we call key populations, female sex workers, injection drug users, men who have sex with men, and partners of those that are known to be positive. So with those groups, it's much, much easier. You test a smaller group of people in order to get a positive. But the theme of this World AIDS Day is all about trying to define the whole population of those with HIV, the whole cohort, of those with HIV. Because if we miss just one person, it's one person too much, really. Because you could be saving a person's life by just making a HIV diagnosis.
Okay. One area that has remained a source of concern has to do with our rates when it comes to prevention of mother-to-child transmission. We as Nigeria as a country, is still rated as a country that boasts of the highest number of such children getting infected, through their mothers. How are we faring in trying to mitigate that?
So we're still struggling in prevention of mother-to-child transmission. In 2017, only about 40% of mothers had a HIV diagnosis, those that should have had a HIV diagnosis. So which means that we missed about 60%. If you look at the entire cascade, what we call the cascade for PMTCT, prevention of mother-to-child transmission, we have two major areas where we have a block or a barrier. The first one has to do with women accessing antenatal services. Unfortunately, in Nigeria, unlike in other countries like Rwanda, for instance, 90% of their women access formal antenatal care. In Nigeria, only about half of our pregnant women access antenatal care, which means that we only have the opportunity in half of the women pregnant. In 2017, we had about 9 million pregnancies estimated, but only 4 million actually went to an antenatal clinic, and we tested about 2.7 million. And out of the 2.7 million we tested, about 0.7% were positive for HIV, and they were put on treatment. So the main barrier really has to do with access to antenatal care. Our women do not like going to formal antenatal facilities. So the only way we can deal with that is to try and work with other parts of the health system, such as the Primary Healthcare Development Agency, state healthcare and state ministries of health, to try and encourage women to go for antenatal care. Otherwise, we will never be able to bridge that gap. The second gap has to do with women who are already on treatment for HIV that are pregnant. A very small proportion of those women actually go to deliver in the healthcare facilities. And if you really want to stop mother-to-child transmission, you need to follow those women right up to the point that they deliver. And for some of them that still have viruses in their bloodstream, we have to do some intervention to make sure that the baby does not get infected.
Do you have mechanisms that's just towards encouraging women, towards that, to make them understand on the need for them to go for antenatal because it's for their own good and that of the unborn child. Do you have, what synergy do you have with relevant bodies that could make that happen?
So a lot of things have been going on. So for instance, Global Fund last year actually gave a grant that enabled us to work closely with maternal and child health services across the country to try and integrate PMTCT into the maternal and child health program, so that when a woman is pregnant and she comes for antenatal, we are not bothering her about just HIV testing. We're actually saying you need a HIV test, you need full blood count, you need a malaria screen, nutritional status, etc. So that HIV is not considered as a standalone sort of diagnosis for pregnant women, and I think that does help. The second thing that we've been doing is we've partnered with the Federal Ministry of Health and a World Bank program called Saving 1 Million Lives, and this has enabled a lot of states to be able to access funds that can be used for providing HIV test kits to the facilities, because some of these facilities do not have HIV test kits, or even if they did, their healthcare workers are not trained properly in order to do a HIV test.
Okay, that takes us back to the issue of commodities now. I know that when it comes to commodities, you have a situation where I've heard people out there talk about the out-of-stock syndrome when it comes to ARVs. Now, especially the pediatrics. Do we still have such challenge?
So things have improved remarkably. So the Federal Ministry of Health, working with us and our partners, we now have a much robust logistics system. The Honorable Minister of Health early in the year launched what they call warehouse in a box, which enables commodities to be brought in and to be distributed more easily. We also have a national pool for antiretrovirals and for test kits as well. So that enables us to distribute HIV drugs based on their expiry date. So the drugs that look like they might expire fairly soon will be pushed out, whereas those that have a longer expiration date will be left behind and will then be distributed to the facilities.
Which means the bottleneck that we used to experience in those days that has to do with clearance is now a thing of the past. Is that what you're saying?
Less of an issue. That's less of an issue. The main problem we are having, in fact, with that is the contribution of government to the pool, because up to this time we are looking after about 60,000 people with HIV in Taraba and Abia. That's only about 5% of the 1.1 million, and the rest are being looked after by the US government and Global Fund. So, which means that really the HIV response is predominantly donor-driven in Nigeria. And if you have a situation where something is predominantly donor-driven, then you would have sustainability issues in the long run. But the federal government has been very much welcoming to a lot of our approaches. The president has already directed that people living in Taraba and Abia should be accommodated properly within the 2019 budget. So we expect things to improve in terms of commodity side from the government side. The private sector also need to.
So the private sector. What about the private sector? What's the partnership like?
What about the private sector? What about the state governments?
Yes.
So the private sector, we've been partnering with the Nigeria business community against AIDS to set up a HIV trust fund. We hope this will be launched fairly soon. Most of the background work has already been done, and the trust fund will be purely owned by the private sector, and their job will be very simple. They will generate funds and they will buy HIV commodities and they will bring them into the national pool. That way their current contribution, which is only 2%, can be pushed to 10% for the national response. And I think that will be very critical, because some of the challenges government really has to do with the cost of these commodities. The 70% of what we spend on HIV, we spend them on the drugs, really. It's not just the management cost, it's actually the drugs and the test kits that are very expensive. We also have the state governments. We've been trying to get them on board. If you remember last year at the National Economic Council, the state governors approved 0.5 to 1% of their monthly federal allocation to go towards HIV. And we've been following this up with some of the state governors. I've visited at least 12 or 14 states so far, and the response I've been getting has been very positive, and in fact some states are already
implemented.
So some states have already put in more than 1%, but of course the release has always been the problem. You can always have a budget, but if you're not releasing the funds, then work done, zero, really. But some states are actually doing pretty well, like Lagos, for instance, like Kaduna. I'm very happy to say they have really invested in HIV. Katsina is also doing pretty well. But there are states that we just have to go there and cajole them and urge them and beg in order for them to look after their own, which I think shouldn't be happening. Really.
I'll take you to the issue of those who wear the shoes, talking about persons living with HIV, and the issue of users fee and all of that. I know it's still an issue, so I'm asking on their behalf now, what has been done? Because if you look at the fact that HIV, there's a linkage between HIV and AIDS and poverty. So
yes, there is.
There
is. So my view, and this is the view of government as well, is nobody should be restricted from having access to HIV medications or treatment simply because he or she cannot afford. A lot of the things we give, we really give for free. So the HIV drugs, for instance, the testing, for instance, even the laboratory tests, CD4 count, HIV viral load, nobody should pay for this.
But facility, still being charged for
so I would like to divide the user fee issue into two, really. There's one part of the user fee which government can do something about, and this is charging for things that really we should be able to accommodate. And we're working with the federal medical centers, the teaching hospitals, and especially the state governments to try and remove those. And then there's the other aspect of the user fees that's really criminal. So charging for prescription charges, for instance, for drugs that we are giving for free is wrong. Charging for laboratory testing, for laboratory reagents, etc., that we are giving for free is wrong. And these things cannot be justified. And even charging for the card. And what I can't understand is for a lot of facilities, they know they are benefiting from the HIV response. If you go to a lot of teaching hospitals and you see a very nice lab or a very nice clinic with electricity, etc., it's going to be a HIV treatment center. So those facilities indirectly are already benefiting from the HIV response, from what we have put into their facilities. And moving forward, for those that are charging criminal charges that really shouldn't exist, we will give them the option of taking away those HIV facilities, because if we take them away, maybe that's when they would realize that we're actually subsidizing their care. In the long term, I think the best way to resolve the HIV issue in terms of user fees is really trying to push forward the concept of universal health care. We already have the Basic Healthcare Provision Fund. I've been discussing with the Honorable Minister to see how this can feed into HIV care. But in the long term, what we need is for whoever goes to a facility not only to be exempted for HIV, but to be exempted for other disease conditions as well. Because it's the easiest way to be able to fund the health system, rather than saying, okay, you have HIV, you will not be charged for full blood count, UNE, but if you come back tomorrow with diabetes, you will be charged. It will be a very difficult system to operate, and it will also promote stigma and discrimination, because it means our constituencies will have to be going around with different laboratory forms, different cards, etc. Especially in terms of long-term sustainability, because if you continue to fragment healthcare, you're not going to have a sustainable system. The only way that long-term we can continue to deliver HIV and accept those people that are on treatment and look after them is really to integrate healthcare into the mainstream health sector, so that when you go to a clinic, it's not labeled as a HIV clinic, but rather it's a general medical clinic where you are seen for malaria and you're seen for HIV, etc., and everything comes together. The days when we used to have facilities only for HIV and laboratory facilities only for HIV has really passed. But we need to find the resources to be able to close the gap when it comes to the user fees. But my approach is, for those things that we provide, anybody charging for them is wrong, and we will be taking a very firm position on this moving forward.
Okay, I know that sometimes back you entered into some sort of collaboration with the National Health Insurance Scheme towards making things easier for persons living with HIV? What had come of that collaboration?
We've been looking at the states, because what we do know from the national level, if you remember, only about 2% of the population are on health insurance at the national level, and these are people in the formal government sector, really. So that's a very small. Unless you have a large cohort of your population on health insurance, that's not going to work. But we've been working with some state governments. Lagos is an example, for instance, where we've looked at the cost. And if the population within Lagos are all put on health insurance, without HIV, it will cost about 8,000 naira per annum per person. With HIV, it will cost about 8,600, just 600 naira additional to what people will be paying as a premium. So we want to work more closely with the state health insurance schemes, because I think that's the best way to bring HIV into the health insurance sector, rather than working purely with NHIS. And we're already doing that. A lot of my advocacy when I go to the state governors, particularly for state governments that are just about to implement state health insurance or contributory schemes, is to ask them to make sure that HIV is included both in the testing as well as in the treatment for people living with the disease.
Okay, I know that not everyone who gets tested or who tests positive to HIV, it's likely to be placed on treatment immediately. It varies, it depends on the viral load. For elder living, I'm talking about nutrition now, how much attention do we pay to people being mindful of nutrition and the role it plays in preventing the virus from progressing?
So that's a good question. So actually things have changed. Now, if you're diagnosed with HIV today, you should be put on treatment virtually immediately, what we call test and treat. We have stopped using immunological parameters such as CD4 count to decide whether you need to go on treatment or not. And that's because the outcome consistently has been shown in studies that you will do much better if you're started early than being allowed to get sicker and then be started on treatment. Nutrition is very important. But you're more likely to be malnourished if you have advanced HIV disease. If you just caught HIV, let's say a year ago or a few months earlier, you're not going to be malnourished. That's why we are putting a lot of emphasis on trying to get the HIV test done pretty early on in the disease. The Vice President, when we did the World AIDS Day a few days ago, did mention that government is also looking at supporting people living with HIV through the federal government social intervention program, because obviously a large number of our constituency are people who are disadvantaged and also do not have a means of livelihood. And without a means of livelihood, being asked to pop a pill every day, and meanwhile you cannot even afford your breakfast or lunch or dinner, it's really difficult. And we know that people living with HIV are disadvantaged, and we have been pushing, but fortunately government has listened to us, and moving forward we hope that more and more of our constituency will be able to access those excellent programs that the federal government has started that covers people that are poor or live in dire situations.
Okay, we really hope Nigeria will do the needful to enable us meet the 2030 target of ending the HIV and AIDS pandemic. Thank you so much, Dr. Sani Aliyu, for making out time to join us on Health Options.
Thank you for having me, Rabi.
One's status is the entry point of accessing HIV services. Nigeria is a global signatory to end AIDS in 2030, which means that every Nigerian that is positive must be placed on treatment. And it is on that note that we conclude this week's edition of Health Options. You can go to our YouTube channel to watch the uploads of these and other episodes. Email us for your comments and contributions at healthoptions@nta.gov.ng. My name is Rabi Abdallah. Thanks for your time.
want to tell us another story again, yo. Now so, you know, say people they say I be superstar. But for me, the real superstars are those people where they go vote for the candidate of their choice without violence. So for these upcoming elections, be my superstar. Vote. No fights. No violence. Because the election will be won.
We work together so the future will be brighter.
What does scoring a football goal and mathematics have in common? In the world of Ubongo kids, everything we do can be related to math and science. Join Kiduchu, Kibena, Koba, Amani, Baraka and their animal friends as they solve problems and go on fun learning adventures.
Don't you see it?